To understand the results of the OCEAN trial, we have to start with the mechanics of atrial fibrillation. This diagram shows a cross-section of the heart's upper chambers experiencing an electrical storm. That chaotic signaling prevents normal pumping, causing blood to pool and form clots. If one of those clots travels up to the brain, it causes a stroke. The standard defense against this is prescribing long-term blood thinners. We lower the risk of clots, but we force the patient to accept a dangerous trade-off, a permanent increase in severe bleeding risks. Catheter ablation was developed to solve this. By creating targeted scars, electrophysiologists can extinguish that chaotic electrical activity. The procedure physically restores a steady rhythm. This creates a clinical problem. If a patient undergoes a successful ablation and their heart remains in rhythm for an entire year, do they still need to risk the severe bleeding associated with daily blood thinners? While ablation fixes the physical rhythm, it was previously unknown if it eliminated the long-term stroke risk. We needed a definitive trial to see what happens when we stop intensive anticoagulation in these stable patients. This map shows the distribution of the OCEAN trial, which enrolled 1,284 patients across 56 centers in 6 countries. Every participant had been free of atrial fibrillation for at least 1 year post-ablation, verified by 24-hour and 48-hour Holter monitors. Researchers also required all patients to have a moderate baseline stroke risk, defined by a CHAD2-DS2 SVASC score of at least 1. These patients were randomized into 2 treatment paths over 3 years. One group took 15 milligrams of rivaroxaban daily, while the other took only 70 to 120 milligrams of aspirin. This setup created a controlled environment to test if a blood thinner is truly necessary for a patient whose heart has remained electrically stable for a full year. To measure success, the trial used brain MRIs to track clinical strokes, systemic embolisms, and covert embolic strokes, silent infarcts measuring 15 millimeters or larger. The primary event rates were low across both groups. The composite stroke outcome occurred in 0.8% of the rivaroxaban group and 1.4% of the aspirin group. Because the absolute number of events was lower than the investigators anticipated, the trial lacked the statistical power to prove a difference between the drugs. While the relative risk was 0.56, the p-value of 0.28 means the results were not statistically significant. The breakdown of subcategories reinforces this. Clinical stroke and embolism rates were 0.8% versus 1.1%. Silent MRI infarcts of 15 millimeters or more were 0% versus 0.3%. Even smaller silent infarcts reached 3.9% versus 4.4%. Now we have to evaluate the safety data. We must compare that small reduction in stroke risk against the blocks representing bleeding. Fatal or major bleeding occurred in 1.6% of patients on rivaroxaban, compared to 0.6% on aspirin. That is a hazard ratio of 2.51. Non-major bleeding followed the same pattern. Clinically relevant non-major bleeding hit 5.5% on rivaroxaban versus 1.6% on aspirin, and minor bleeding reached 11.5% versus 3.1%. Pause and consider the trade-off. As a clinician, how do you weigh a non-significant 0.8% stroke risk against a 5.5% bleeding risk? These results challenge the assumption that the protective benefits of blood thinners always outweigh their bleeding risks for this specific patient profile. Translating these numbers into practice provide a specific clinical insight. For these rhythm-controlled patients, rivaroxaban doesn't offer a statistically significant advantage in stroke prevention over aspirin, but it does carry a higher risk of bleeding. Because of this data, de-escalating to aspirin, or stopping blood thinners entirely, is a viable, evidence-based path for moderate-risk patients who are strictly monitored and remain arrhythmia-free. However, this path does not apply to the high-risk patients excluded from the trial, such as those with prior strokes or heavily damaged left atria. This final visualization gathers the core findings into one view. First, successful ablation lowers the baseline stroke risk. Second, rivaroxaban's efficacy over aspirin was not statistically significant. Third, rivaroxaban increased major bleeding. And fourth, de-escalation is a valid consideration for monitored patients. Modern medicine requires us to prevent a storm when the danger is high, but it also requires the clinical wisdom to look at the data, see the clear skies, and know when it is safe to put away the umbrella.